Hello, everyone. I know some of you are still coming through, but we want to say welcome. And this webinar is being recorded, so you can go back and watch, and we will share a link with you as well. So just keep coming through. We want to welcome everyone to Prepare to Repair, Innovative Approaches to Wounds webinar. And firstly, I would like, in the spirit of reconciliation, to acknowledge the traditional custodians of country throughout Australia and the connections to land, sea, and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people here today. My name is Anne Loam Dalhoff. It's a Danish accent, so I hope you understand what I'm saying. I'm the marketing director at Team Medical Supplies. And at Team Medical, we're committed to providing quality education to support you in practice. Today's webinar topic is innovative approaches to wounds. And thanks to our partners from Oraderm, and Nicole is here, Nicole Lind is with us here tonight as well. Thank you for making today's webinar possible. We appreciate it. Just a bit of housekeeping before I hand you over to Dr. Rigolski. So great to have so many of you with us here. All your cameras, all your microphones are muted, so don't worry. You can eat dinner, have a cup of coffee while you lean in and engage. We do encourage everyone to participate through the chat box. So to make sure it works for you, please everybody open the chat box now. It's at the top, click chat and say a quick hi or hello and where you're from. Then you know your fingers can do it and we know that we've got connection with you all. So we're looking forward to all the highs and hellos coming through and where you're from. If you have any technical questions, just put a comment in. Our team behind the scene will help you out. Oh, that's lovely. See all of that, Matthew. We've got them from everywhere. That's so good.
Great.
I'm going to be quick with these ones. We're recording it. You'll get the link in an email tomorrow, and the link will be added to our teammet.com.au website on the events page. So you can always watch on demand there. Our speaker will share informative presentation and there will be a Q&A session at the end, and we're leaving plenty of time for that. When we get to it, please put your questions in the chat, just like you're saying g'day and hello at the moment, and we will shoot these questions back to Dr. Matthew Rigolski to answer. We can't wait for that part of it. At the very end, there'll be a survey link. Please take a minute to fill it out. This really allows us to continue improving our webinars and deliver content that's relevant for you and those joining next time. Now, today is our expert speaker, Dr. Matthew Rigolski, DPM, FFPM, RCPS, Glasgow. Dr. Matthew Rigolski has been in practice for 19 years. He's a fellow faculty in podiatric medicine at the Royal College of Physicians and Surgeons in Glasgow. He serves as the medical director of the Wound Institute of Ocean County, New Jersey. And that's why he's up very early today and it's a bit late for us. Additionally, he has been the PI of 20 RCTs in wound healing. Dr. Matthew Rigolski has authored over 70 articles in peer-reviewed journals on topics such as wound healing, biofilm, chronic infection, and limb salvage surgery. So I will now pass over to Dr. Matthew Rigolski. Thank you so much for being with us. Take it away.
Yes, ma'am. Thank you very much, Anne. I appreciate it, everyone. Appreciate you guys being on after a long day. Yes, it is very early here, but I'm always an early riser. Anytime I get to chit-chat about wound healing things, I always enjoy because it is so fantastical. You know, when we think about, if we can advance the slide, please. When we talk about chronic wounds and wound healing and all that good stuff, there's a lot of things that go into it. Unfortunately, as these wounds are getting worse and occurring more often, the treatments from those become quite encompassing because there's really not one thing that is going to fix this problem. Chronic wounds are a multifactorial problem. They are going to require
I'm just going to pause you there, Matthew. I have your video, but you just went muted. I don't think it's just me. I think the sound just muted. So let's get you back on sound as well. I can't hear you yet. But we can see you, which we couldn't before. So that's good. But let's see. It is a bit different for you as the speaker, whatever happened there. Try up.
Can you hear me
Close.
now?
Yes.
Okay.
Beautiful. So if you just
Great.
take 1 second back what you're talking about, and we're with you.
Sure. Okay. So I apologize, everybody, for the difficulties. I'm terribly sorry. But this is Blastex, and I've been fortunate to be involved with this wonderful technology, doing some of the first clinical studies on it in 2014. So I probably used it on over 1.5 million applications, multitude of patients. I treat about 10,000 wounds a year. I'm fortunate to be into that position in a very large group in an academic setting. So it's very wonderful to have something that can address this problem of biofilm and chronic infection. Next slide, please. So when we I know this is maybe out of the scope of some of you, but it's just an interesting thing to wonder about some of the really egregious and repugnant treatments that are going on out there on some of these patients. This was a diabetic patient, dialysis patient, who came into my office with this wound for 6 months, as you can see, with those heel bones sticking out, quite necrotic, diabetic dialysis, very bad vascular disease, but just had a nice long leg bypass done. But yet the treatments that were being put on this patient were, in my mind, quite negligent, because they were having him soaking it in Epsom salt and put Silvadene cream on it. So for the last 6 months, it's really difficult to see things like this come into your office when you could have fixed these ages ago. But next slide. When you look at talking about chronic wounds, so I developed a paradigm because after 19 years of practice, I learned a little something. And I teach my resident physicians about this. When you look at any wound patient, you want to think about this paradigm. Because if you don't, then something gets missed in the treatment protocols for these patients, because wound healing is so complex, so fantastic. I think it's important that we cover all of these areas because, again, wound healing is a multifactorial problem a chronic wound is, and the wound healing prospects require multimodal therapy, but it all starts with biofilm and chronic infection, because every chronic wound is going to have bacterial component to it. You have 1 billion bacteria per square centimeter on your body. Any open wound is going to have some bacterial component to it. And if you don't believe me, run a swab across any chronic wound and you'll see that it will grow something, considering that 95% of the bacteria live in a viable non-culturable state. Next slide, please. So I think it's important that we understand that paradigm and that we move through that each and every time that we see these patients. So that's why I developed it. I trademarked that name, and then I also published it in 2 journals. So the Blastex here is powered by the XBio technology. And the XBio technology has multitude of effects, and it's really some simple components in an elegant chemistry in which its action is very masterful and absolute. So when we look at all of the components to this in 10 seconds, this is the reason that we utilize this gel for the wound healing cascade. Because with these wonderful properties that it does have, and I think that you understand that something that can work for 5 days has great attributes. If you might not see the patient often, if the patient lives in a very rural community and can't get to see you, but it makes it wonderful, especially for our visiting nurses, to be able to go out and apply this and have confidence that it sustains for 5 days. 7 log reduction in 2 minutes. That's 99.99999% of bacteria is killed within that very quick amount of time, and fungus as well. It's very non-toxic. It's biocompatible. And that's another good key feature, because there are things out there that can destroy chronic infection and biofilm, but also destroy your healing cells that can be toxic to fibroblasts and keratinocytes, to endothelial cells. But at the same time, with the broad spectrum efficacy. So the XBio technology that powers Blastex has an effect to kill planktonic bacteria and fungus, but also the biofilm bacteria that's contained inside, both resistant and viable non-culturable cells, and also the EPS, which we will get into so that you understand that, which is that protective covering, like a big house that you put built around the bacteria and held together by bricks and mortar. And those bricks and mortar are specifically going to be components that we'll talk about that the X biotechnology has the capability to strip that away. But as an evidence-based physician, there are two RCTs that when you use BlastX powered by that X biotechnology in conjunction with good standard of care, there's vast improvement in your wound healing outcomes, proven again through a randomized controlled trial, which is the highest level of evidence that we do have. I think when you look at the healing rates here in the United States and Australia, when we look at things for standard of care, it's not great. Okay, it's not great. I think because maybe we don't know all about the wound healing process, but I also think that evidence-based medicine is not being followed. People may not understand all the reasons that engender a chronic wound, and there's a lot of things that we have to do to mitigate those. And again, it's wide encompassing. And sometimes it's not understood by the people that are treating those, but that's why we have these dismal rates. When you look at venous leg ulcer, which is probably the most common lower extremity ulceration, 3% of the world's population has a venous leg ulcer. Over the age of 65, that goes up to 6% of people. 93% are open longer than a year. 7% are open longer than 5 years. And here in the States, diabetic foot ulcer occurs every 1.2 seconds in the United States. So again, with 330 million people. And we have here in this country, unfortunately, we have almost 40 million diabetics and we have 100 million people warming up with the disease. So I think it's pretty scary how chronic wounds are increasing exponentially. And but the treatments, unfortunately, aren't keeping up with that. That's a good thing to know that we do have BlastX in our armamentarium to handle chronic infection and biofilm and help with that healing cascade. And diabetes is worldwide right now. By the year 2030, 25% of the world's population will be diabetic. In the year 2045, that's going to go to 52% of the world's population will be diabetic. It's the costliest disease in the history of mankind. We spent in 2021 $976 billion in the treatment of diabetes and its related complications. It's the number one reason that diabetics are admitted to the hospital is for foot ulcer. No other reason. And when people do have diabetic foot ulcer, which really scares me even more because I come from a long line of diabetic people, is that when you have that diabetic foot ulcer, you're 2.5 times more likely to be admitted to the hospital and 1.5 times more likely to die during that diabetic foot ulcer period because of the chronic inflammation that is coursing through the body, because diabetes affects every system in the body. That's why they need a multitude of doctors to treat that and help with that. But when you think about the cost of this, which is more deadly than all these cancers combined, except for pancreatic cancer, diabetic foot ulcer has a 47% mortality rate. Scary. And unfortunately, with you down in the great country of Australia, that you're going to be seeing the increased risks of those complications. When you look at surgical site infections, which I was just looking at the statistics here in the United States, that people that had a total knee done and they get an infection, that carries a 20% mortality rate, which I didn't know it was that high. And again, with the increasing numbers of diabetes and other chronic diseases, and it all starts with obesity too, because obesity engenders type 2 diabetes. Obesity is associated with 236 chronic diseases and 13 cancers. But unfortunately, I think if we could just get people to eat a little better and do some exercise, we could get rid of half the chronic disease in the world. But it's just going to keep increasing exponentially. So it's nice to know that we have something in our armamentarium that we can handle the chronic wounds and the chronic infections that come through. But again, even though we're putting this great gel on things, you have to do in conjunction with good standard of care. Now, when we talk about what actually biofilm and planktonic, so remember, planktonic cells are very freely floating cells. They are very normal, so to speak, good metabolism, rapidly proliferating. When cells get into the biofilm mode of growth, when they convert from planktonic into the biofilm, they become quite dormant. They can become quite relaxed. Stress-related genes are downregulated. They feel comfortable. They feel happy. Okay, so that's an interesting thing about biofilm. It's without a lot of stress reduction, they're not actively metabolically proliferating, very difficult for antibiotic to get to them because of this something called the extracellular polymeric substance that's being secreted by these different bacteria and fungus in the wound so that they can be protected, safe, and comfortable. You cannot see biofilm. You need an electron microscope to see that. But when you look at a chronic wound, all that slough, all that fibrinous junky tissue that's in there, that is the sequelae of chronic inflammation and collateral host tissue damage. But it's I love it, this kind of like the iceberg formulation, because you can, when you look at the stuff on the surface, that's the normal proliferating planktonic bacteria. But below that surface, that's where the real danger lies. And here in the US, our National Institute of Health will tell you that 80 to 90% of all infections are biofilm related. And that's what makes them very difficult to eradicate, because they are in a dormant phase. They are relaxed. They are kind of, so to speak, sleepy, but they're protected by the extracellular polymeric substance. That's what makes it very difficult to get at them because of this thing called the EPS. And there may be some true resistant bacteria, but they exist mostly in something called the persistent state or a viable non-culturable state as well. So we used to think about by the year 2050 that over 10 million people would have antimicrobial resistant infections. And now here in the States, the CDC gets called every 30 seconds every 30 minutes for an antimicrobial resistant infection, believe it or not, which is, I found that very interesting, that statistic. And that's pretty scary as well, because we live in such a litigious society that antibiotics are given out for every little sniffle, every little cough. And how about with chronic wounds? I've seen people, I just had a lady that came 2 days ago who had a venous leg ulceration for 8 months, and she had 8 different prescriptions for an oral antibiotic. Now, there's no evidence for that. There's no RCTs to show that antibiotics equate to any wound healing. Topical antibiotics, there's no evidence for topical antibiotics as well. I point you to the European Wound Management paper of 2022 to show you that there is very little to no evidence for the use of topical antibiotics, but it's used all the time. So I think when we understand what the biofilm does to your immune system, that it can suppress it, it can overstimulate it. It wants to create collateral host tissue damage through chronic inflammation because it lives off that percolating wound fluid. It keeps the wound broken down so that it can absorb protein and other foodstuffs that come through your wound fluid. And it does that very sinisterly, either, like I said, suppressing that immune system or overstimulating the immune system. But we also thought that by 2050, we were going to see all of these deaths from antimicrobial resistant infection, but unfortunately, it's occurring since 2019. And I point you to these papers in the Lancet. Right now, 5 million people have died from antimicrobial resistant infections. 1.5 million directly, 3.5 million indirectly. Go to the next slide, please. And I'll show you, these are the references for that. I encourage you to look at that and read that, because it's kind of startling when you understand what is going on. And it makes sense, right? Because we're giving out antibiotics for every little sniffle, every little open wound, even though there's not the true indications for antibiotics. Big zone of erythema, purulent drainage, exposed bone or tendon, maybe some hardware, things of that nature to show the real clinical representation of an acute infection. We just see my internal medicine colleagues, and I've given multiple lectures in my health system about that. They just see any chronic wound, they run a swab over it, shows some bacteria, they give an antibiotic without the true indication. So now we have antimicrobial resistance that is pretty pervasive throughout the system. And this is a great picture is. This is one of the first infected total hips. This is a picture from 1973. And when you look at the acetabular component, and they take a portion of that and they put it under electron microscopy, you can start to see this biofilm mass, a lot of these clusters of staph that you can see, and held together by that thick, gummy EPS. It's just a fascinating picture. I thought I'd give you a little idea of what it looks like. This is a picture of a slide of patient with cystic fibrosis and looking at all those little black dots. Those are neutrophils that are trying to get through, and the neutrophils are the wolves of your immune system. They're your first responder. He's the guy that is going to be there in the first couple of minutes to attack this. But I just wanted to see the population, how huge it is of neutrophils trying to get through that big sugary swamp. Pseudomonas, very nasty bacteria, does some really destructive things to our immune system, can lyse them very quickly through the production of something called rhamnolipids. Fascinating. Next slide. And then when this is going to be, these are macrophages trying to get through a Staph aureus biofilm. And when you look at MACs, they're those big orange cells that you have there. Think of them as the lions of the immune system. They kind of come down, they gobble up the apoptotic neutrophils through the process of erythrocytosis, resolve that chronic inflammation. They secrete a multitude of growth factors and reparative proteins to help move the wound on into that proliferative phase of wound healing. But look how thick and gummy that is, how big, swampy, sugary mess, and these guys are trying to get through there, and it does not work very well, as you can see from that section of biofilm. Next slide. And this is I really use this schematic a lot when I'm lecturing about what biofilm and chronic infection are. So you may do a nice debridement on the patient's wound, whether you're using a scalpel or a curette or some type of ultrasound device, or even mechanical with a good 4x4 in there and debriding the wound. But this is how fast that it can recur. And what do we do to protect our debridement? It's a good thing that we have the X biotechnology that has efficacy for 5 days. But this is Staph, and he's shooting out these fibrinogen tangles, these fibrinogen type proteins with an N-acetylglucosamine sugar attached to that, and they're making these big strands, almost like this big web of his EPS for protection. And you can see that it's really fully formed in about an hour. You're going to have these microcolonies of this mass. And even though that it talks about 24 hours, I've seen papers to show that it becomes fully mature in 5 hours. So you do a great debridement, and then as few as just a few minutes later, it starts to form, and then it can be fully mature in just a couple hours. So it's fantastical how that comes back and is being spun by these bacteria to protect themselves and keep themselves safe and keep them in a very relaxed state so they can go about causing collateral host tissue damage. Next slide. So this is a nice picture of what actually you're looking at when you talk about biofilm. This is the EPS. Go back, please, one. This is the EPS that you see there, and that's that big gummy structure that is being produced by these bacteria in there. So you can see that nice picture of it. And then you can see even in between all the different bacterial species, you can see the gram-positive, gram-negative rods there, and there's those gram-positive clusters. And you see all that gummy attachment between that. And that's what is really fascinating, because these are being produced by these little one-cell organs, this very complex structure, very difficult to penetrate, get rid of, that is going to be there causing collateral host tissue damage and chronic inflammation. But it's held together by these metal ions. Next slide. And these metal ions are the linchpin of the extracellular polymeric substance. Now, in chronic wounds, that's going to be an iron molecule. When you look at things from cystic fibrosis, that's a zinc molecule, and then otitis and sinus, it's a calcium molecule. But the metal ions are really, think about when you build a house out of bricks and mortar. So the mortar is going to be those metal ions. All the bricks around it, those blue and red dots, those are polymers. Sugars are the big one. They're ubiquitous throughout all of these different biofilms. And then, of course, there's also going to be proteins. There's extracellular DNA both from bacterial and host. There's lipids, and there's also biosurfactants and other proteases in there. But the polymers, think of them as the bricks. Okay, so the metal ions are the mortar, the polymers are the bricks. Very strong, very stable, very rigid protective structure. The metal ions are the linchpin. If we can dissolve the mortar, we can unzip the EPS and then expose the bacteria and fungi. So that is going to be the lynch. So the EPS that you see there, that is 90% of the dry weight of the biofilm mass. Bacteria and fungus are only about 2 to 10% inside there. It really is that big, nice brick house that is being built around them to protect them so that they can go to work on your tissue, causing chronic inflammation and collateral host tissue damage. Next slide, please. So you wonder about things that we can utilize to treat biofilm. And again, I told you there are things out there that can destroy biofilm, but will also destroy your good tissue, and your healing cells as well can be quite toxic to them. And for the longest time, I've done multiple clinical trials on different things. When we first started out into practice, because in medical school, they teach you nothing about wound healing, zero. And even in my residency, we did a lot of this, but we never really got down to understanding the molecular concepts of treating these problems. So it was wonderful to move along into the Blastex gel powered by that X biotechnology, because it does so many things. How do we address the EPS? Because that big protective covering, how do we rip that away? How do we get at these resistant or persistent and dormant bacteria and fungus that are lying in there? How do we do that in a biocompatible way? Because there is really not anything out there that can hit all of those check marks right now, except for the Blastex gel powered by that X biotechnology. How can we debride and remove all of that stuff, but in a safe, biocompatible fashion, and most of all, protect it from coming back? Next slide. So there is a consensus document. I encourage you to read this so that you can understand that. But we want to talk about hitting that right and getting rid of that biofilm mess, that chronic inflammatory nidus, right from day one. As I told you, there is 1 billion bacteria per square centimeter. So part of the prepare to repair mantra and that paradigm that I developed, we got to attack that chronic infection that is occurring in all chronic wounds. There will be always a significant bacterial component to it, because that's one of the niduses of the chronic inflammatory cascade that keep the tissue broken down and stuck in inflammation. Next slide, please. Right, so that's what we talk about that. And when we look at what that means, that biofilm keeps the wound stuck and broken down. When I was a medical student, again, they teach you nothing about the wound healing cascade, and even in the residency, it was still very iffy about what does that mean when things are stuck in inflammation. We talk about chronic wounds being stuck in the inflammatory cascade, and biofilm is one of those major instigators that do that. It can suppress your immune system. It can overstimulate your immune system to break down that tissue and live off that percolating wound fluid. And by doing that, also, it consumes a lot of the oxygen in the wound, both the aerobic bacteria that live on the surface of that biofilm, but also then your white blood cells are coming down, being stimulated constantly by the immunogenicity of the biofilm mass, because it's highly stimulatory to your immune system, the sugars, the proteins that are in the specific antigens that are counted in those matrix components. So your white cells are coming down. They're consuming all the oxygen in the wound as well, using it as an oxidative burst, trying to get through that biofilm, but it bounces off and it destroys the matrix around. So there's a lot of these things called MMPs that you may be familiar with, all these different proteases. So they're consuming the oxygen, keeping the wound very hypoxic, as all chronic wounds are very low in oxygen, but at the same time constantly stimulating the immune system down there, trying to destroy it. It wants to secrete different interleukins to bring your white cells there constantly, trying to break down that tissue, but it's breaking down the surrounding matrix. So you have a double whammy that is going on in there, destroying the collateral host tissue. It's going to be destroying growth factors in the wound, creating this thing called cellular senescence, where these cells don't apoptose. They just keep pumping out hydrolytic enzymes and proteases, and they destroy the matrix around there, keeping the tissue broken down, inflamed, and draining. Next slide, please. Now, as we've talked about, that there are some therapies out there, or biocides that you can put on stuff that can perhaps have an effect upon the biofilm, but also can be highly dysfunctional to your healing tissue cells, can have significant toxicities. So when you think about things like silver-based products, they don't have the capability to chelate the metal ions within the EPS, that mortar. They don't have the ability to pull that out into solution and strip away that EPS. A lot of these iodine preparations, hypochlorous acid-based products, you have to irrigate them out in 5 minutes according to their IFU. All right. And they don't have that capability to chelate those metal ions in there. And that, again, is going to be the crux of it. PHMB, whether it's going to be silver and these hypochlorous acid-based products as well, do not have that capability. They can react well with the planktonic bacteria on the surface of that biofilm, like we showed you again with that iceberg formulation, looking at the bacteria on the surface of that, but they don't have the capability to go into that, grab that mortar, the metal ions, and be able to strip that away, thereby stripping the EPS. They do not have that capability. So I encourage you to understand the mechanism of action of things that you are utilizing to treat chronic infection in biofilm, and realize that on the physiological basis, on that molecular aspect, that they cannot do that chelation like the X biotechnology does in the BlastX gel. Next slide. And, and this is really the ingredients. Very simple components, elegant chemistry, masterful and absolute in its function. And these are just these simple components. This is not earth-shattering stuff. This is stuff that has been out, and obviously, I mean, benzalkonium chloride is on the FDA list of inert ingredients. You'll find it in shampoos and in makeups and things of that nature. Sodium citrate and citric acid have been around in all kinds of surface cleaners. And of course, your cells utilize citric acid in the tricarboxylic acid cycle for making ATP within your mitochondria. And polyethylene glycol is used to maintain the nice moisture balance that we need for proper wound healing. And it's always interesting, too, when we talk about moisture balance. How many times have we seen wounds that people have been leaving open to air? You've known since 1958 that we don't leave wounds open to air. That was one of the first blister studies that were done. But at the same time, we know they can't be soaking wet. You can't be taking a shower, putting dial soap on it, and all that stuff, too. No evidence for that either. So that's why there is polyethylene glycol in there to maintain help with a proper moisture balance to facilitate healing. Next slide. So we talk about this X biotechnology doing specific things, and that's what the sodium citrate and the citric acids are. They're going to go in there, they're going to grab onto those metal ions and just rip them out into solution. That's why we talk about deconstructing that biofilm mass. They also lower the pH. Most chronic wounds are in a very alkaline pH. That's how proteases function well at a high pH. And because this is an acid, it buffers that pH solution. It drops that pH solution because that's better in a slightly acidic formulation to help facilitate cell migration. So that's where we talk about deconstructing the biofilm. It goes on, it grabs those metal ions, rip them out into solution. But at the same time, because of this high osmolarity that is going on, and because of the surfactant capabilities of that, next slide, please, that the surfactant component now, once we have stripped away that EPS, the surfactant component is going to be doing things to attack the membranes of these cells, and I'll show you that as well. But this is the problem, is that also what is germane to the conversation, being that it holds on to those metal ions for 5 days, doesn't allow the mortar to come back, so to make that rigidity to your brick house. It becomes very, very flimsy, very friable. You're able to knock it over with a feather because it won't have that the mortar to hold all those bricks together. And that's why we can see that, and I'll show you the evidence for that. Next slide, please, how that it's going to prevent that from coming back. And that's a great thing to know, that you can use this in your clinic, in your office. The visiting nurses can use it when they go out to see patients, and use it really on any chronic wound, which is beautiful because of the biocompatibility. But again, because of these simple components as they work in concert, are masterful in its action. And you don't need a lot of it. You want to just kind of cover the wound into about the thickness of a nickel. I do take some extra and spread it around the peri-wound tissue because I want to kill that bacteria on the tissue. Again, I told you that you have 1 billion bacteria per square centimeter. Next slide. But again, fostering a proper moisture balance, but also removing that inflammatory nidus, which is the biofilm mass and that extracellular polymeric substance. And these are just a smattering of some of the wonderful proof that there is for, and the evidence of the X biotechnology able to attack MRSA and Pseudomonas and fungi. Especially, we're starting to see more fungus occurring in these wounds, and I'm assuming down under too. We see more fungal species because of the climate down that way. But we're having here in the States a lot of resistant fungus at this point. A lot of Candida species that are resistant to most every antifungal. It's a good thing to know that you have a technology that is a homicidal maniac, so to speak, on chronic infection. It really can do a super job removing that concern for you in that chronic infection. And this is some of the proof that do it. I mean, when you look at how quick that this attacks it because of that targeted chemistry, no antimicrobials in it, no antibiotics in it, no toxicity associated with that great biocompatibility to it. But I think it's really important that we understand that this works for an extended period of time. I don't know anything in the market that has that capability to work as long as this does, preventing that biofilm reformation. So that's why we talk about it deconstructing the EPS, destroying these pathogens, but defending, next slide, against the reformation of your biofilm mass.
Dr. Rogolski, it's just
Yes,
Anne
ma'am.
Lone here jumping in. This is so amazing. And I'm just sharing that we've actually got quite a lot of questions already. So I'm
Okay.
wondering for the slides, if you can maybe have a quick,
Sure.
go through some slides so that we have enough time because there's some really great questions. Thank you.
Yes, ma'am. This is this is a 72-hour drip flow reactor. So they grow biofilm for 3 days, very mature, very thick, virulent fungus and bacteria. And then they show the 8-log reduction of this within a 24-hour period. Next slide. And at the same time, this is the comparison against a multitude of antibiotics that are out there, treating it in a 3-day-old biofilm, very thick, very virulent, very mature. Next slide. And just real quick about MMPs, these are proteases that are being produced in the wound by your immune cells to kill biofilm. They have two calcium and a zinc molecule. The X biotechnology is able to bind to that because it binds to metal ions, neutralizes these proteases for invasion of tissue. Next slide. And again, reducing the inflammation, because by doing that, as we lower that inflammatory cascade, then it is able for this the movement on through that healing paradigm, because chronic inflammation is a major nidus of collateral host tissue damage, keeping the wounds broken down and stuck in the inflammatory phase of wound healing. Next slide. These are the clinical trials. Just remember that we have 2 clinical trials, next slide, to prove that the X biotechnology in the BlastX can increase your wound healing rates. You can get copies of these studies so that you can read through them at your leisure, but this was done on wounds that have a very long time, 21 months, large wounds. And next slide, and showing that the healing rates of this were significant. Remember, BlastX was never made to heal. Its job was to kill bacteria, to kill that fungus, to kill that biofilm. But when you used it in good conjunction with a good comprehensive standard of care, it had significant healing rates. These were all the different bacteria that they found at the Mayo Clinic that this was able to defeat and destroy because of the targeted chemistry. Next slide. And so, again, really great healing rates because of that targeted approach, but using it in conjunction, next slide, with good standard of care. This was the other wound healing done by Randy Wolcott at Texas Tech. Next slide. And he utilized, for his standard of care, I just want to point out his standard of care was something called lipogel, which was hamilton, xylitol, and gallium with antibiotics, believe it or not. Why that was his standard of care, why he was making a high-strength topical antibacterial formulation based off 16S ribosomal RNA testing. And then he would use this high-strength topical gel antibiotic for his standard of care. Next slide. So when you look at the outcomes from this, when we utilize the blast, because of that great X biotechnology, utilize that, we had up to an 80% healing rate, which was statistically significant compared to standard of care. Next slide. Use it with everything. It's compatible with tissue. We just talk about a little bit of an alginate because alginate has calcium in it. And the technology will start to break down the alginate. It'll have no effect if you utilize it on the X biotechnology, but it can start to break down, reduce some of the absorptiveness of the alginate. Next slide. Okay, apply it on all kinds of wounds, apply it to the thickness of a nickel, appropriate secondary bandage. Go ahead, next slide. Using it on a variety of different wounds. Remember, every chronic wound, there is going to be significant biofilm and bacterial contamination. Even acute wounds, they talk about 10 to 15% will have biofilm. I really think it's more. Run a swab over it. It's going to show some bacteria, 1 billion bacteria per square centimeter on your body. Next slide. And again, the appropriate covering it to the thickness of a nickel, a little bit on the periwound, kill the bacteria in the periwound, appropriate secondary bandage. Simple and easy. Okay, so think about all these good things that it's going to do. Next slide. It has so many capabilities, all in a non-toxic formulation, great evidence base to it. So when you think about the things that you need to do, just think about a comprehensive approach. We're just not going to put blast on everybody, and everybody's going to do great. You got to think about all the things that cause that wound too as well. And we need to mitigate as many of these circumstances, next slide, as possible. But I think it's great to know that when you're talking about a chronic wound and you have chronic infection and biofilm mass, then we're going to have something that is in there to destroy this bacteria, deconstruct the EPS, defend it, protect it from that EPS coming back 4 or 5 days, all in a non-toxic formulation that is conducive to proper wound healing cascade. Okay, so that next slide just has my email address. If you ever want to talk about cases, you want to talk about, you have questions or things you want to chit chat about, the chemistry, the science, please feel free to contact me anytime. And thank you for tuning in after a long day at work. I appreciate it.
Thank you. We appreciate it so much. And thanks for speeding through our technical issues. So have a glass of water if you have one, because I'm going to shoot questions your way.
Fire.
And excellent. We start from the top. What if the wound has very high levels of exudate when dressings are soaked within 24 hours?
Well, the point is that exudate is going to be part of the inflammatory cascade. It's part of the drainage of wounds. So if you put it on, yes, it does have polyethylene glycol. It helps with some of the moisture balancing. But again, you've got to have something to absorb the inflammatory exudate. I do put collagen into the wound because there's high levels of evidence for that. Cellular scaffold binding proteases in the wound, but you need something to absorb the drain. I use a lot of Draw-Tex over the top of it. You have to pull that inflammatory fluid off of the wound. It's highly proteolytic. If it sits on the wound edge, it's going to macerate, break it down, and get red, and you're going to have an odor. So then you think you have infection, but you got to wick that excess edematous fluid out. It's part of the inflammatory cascade. You get a lot of lymph reflux inside there. It's a lot of lymph fluid too. You have to absorb the drainage. That is also key. That's just part of the prepare to repair paradigm. You've got to absorb the drainage.
Nice. 2. What is the polymer base of the Blastex gel, and what is the active ingredient?
Well, the active ingredients are, we went over the sodium citrate, the
and
citric acid.
And this was from earlier, so
yeah,
it might have been covered. Let's repeat.
Right. The benzalkonium chloride. So sodium citrate, citric acid, benzalkonium chloride, 2 variations of polyethylene glycol. No antibiotics, nothing, no antibiotic in there whatsoever. It's just, again, that good targeted chemistry, simple components, masterful chemistry that it does to deconstruct the EPS, destroy, and then defend. Those are the active ingredients in very small amounts, by the way. Not a lot of it, but just working together to do that deconstruction.
Great. Has Blastex been used on lymphedema wounds?
Yes, you can. I've used it. I unfortunately, we see a lot of that venous leg wounds, lymphedema, but a lot of chronic wounds are going to have a lymphodematous component to it. That's why it causes a lot of that drainage. But yes, you can use it on any chronic wound. I don't see a reason you can't. I use it on radiation stuff, post-Mohs surgery, surgical procedures that have dehisced, traumatic wounds, collagen vascular diseases, because they're all going to have a significant a bioburden and biofilm component to it, causing that collateral host tissue damage. You can use it on any chronic wound, sure.
Thank you. And then just a comment from a participant. Oh, wow, that cystic fibrosis slide was a fascinating construct. The idea that an immunocompromising disease can behave in a similar way to a biofilm is pretty scary. So I'm just going to leave. Yeah. Or you comment on it.
Let me just make a quick comment. Well, because that's what is stimulating the chronic inflammation. The immunogenicity of the biofilm mass, the EPS, is keep pulling your immune cells to there. They're trying to break through it, releasing proteases, bouncing off that EPS, and destroying the matrix around. Cystic fibrosis, COPD, pulmonary fibrosis, chronic bronchitis, especially in the lungs. It's all biofilm. 90% of your chronic infections are biofilm related. I happen to think that it's even more of that. But when you think of sinus and otitis and all the chronic lung diseases, when you look at prostatitis as significant biofilm, we see biofilm in atherosclerotic plaques that are removed after carotid or femoral endarterectomy. They have significant gram-negative biofilm on that. All these chronic diseases are because it's a protective function spun by these pathogens to protect themselves so they can continue to break down your tissue and live.
Yeah, thanks for bringing that message through.
Sure.
A question that a participant was actually helping answer as well in the chat, but I'm going to give it to you. How is it different to Prontosan?
Well, yeah, well, again, being Prontosan is just a surfactant. This has a surfactant in it, the Blastex does, with it being the benzalkonium chloride. But surfactants only work on cellular membranes. They can't chelate by themselves. That's why we have the sodium citrate and the citric acid to grab those metal ions, unzip the biofilm mass, strip away the EPS, and then the surfactant can go in and blow holes in the membrane because how that chemistry of what a surfactant does and allow those components to lyse out of the bacterial cell. But again, prontosin does not have the capability to chelate. It's been removed from the United States because of anaphylaxis concerns here. But again, it doesn't have that targeted chemistry to be able to chelate the metal ions and dissolve that mortar holding those bricks together.
Right. Finding non-antimicrobial methods of promoting wound healing is so important. How do you see infrared therapy as having a place in wound healing?
Well, I mean, I've done some work with different lasers and that type of stuff. But again, it's got to be proven through randomized control. It may have good sound science behind it. But again, when you get into that chronic wound treatment, remember there's so many things that work together to cause the chronic wound. That's why we need more than one thing to fix the chronic wound. That's why I developed that prepare to repair paradigm. Because I think, we've done some work with cold plasma and things of that nature, but it's got to be proven out through RCT, and that's going to take several years. So in the meantime, please utilize this simple gel to do all of those good things that we have talked about. But it may have a place, but we got to really test it through randomized control trial.
Yeah. People with diabetes can have anemia of chronic disease and are given multiple iron infusions. Do iron infusions promote biofilm formation in people with chronic wounds?
You know what? I have not seen any evidence to that. Yes, when you talk about in the chronic wound, that the biofilm mass will take the iron in that wound because of lysed RBCs and can help and incorporate that into. That's another fascinating thing about the biofilm mass is that it can take components from lysed PMNs, macrophages, and competing microbial populations and utilize their actin, their DNA, and do patchwork onto their EPS, making it even thicker. But in a chronic wound, it is an iron molecule that is the metal ions that is holding that together. That's more from the lysed red blood cells that occur in the wound. But as far as giving iron supplementation, I don't know of any evidence to show that that fosters a biofilm. But iron is highly inflammatory. That is true. But I don't know of any evidence to prove that.
Thank you. Does it work as effectively against early forming biofilms as against mature formed biofilms?
Well, the evidence shows it that mature biofilms, an early forming biofilm, some people utilize this Canadian method or the MBEC model, which is a very 1-hour-old biofilm. Lots of things, very naive, it's young, lots of things can handle that. You really want to be testing on these very mature 3-day-old biofilms. That's the highest level of evidence there is to prove that it can do that. Yes, it can use it in an acute wound. You can use, because it does kill planktonic cells in 2 minutes, but for that significant log reduction because of the XBio technology. Yes, it can. Very much. And of course, on the very virulent, mature, multi-species biofilms, it's a homicidal maniac.
Fantastic. And the questions are coming still. So we'll
Good.
just keep going. And
Keep
if
going,
time's
keep going.
out, I want everybody to know this is so amazing. We love the questions. We love this. If this is and thanks for the thumbs up. We might be back next year at some point, so no one panic, just keep the
You can
questions
email me
coming.
too. Please email me. Yeah.
And email questions. Yeah, thank
Yes.
you. Appreciate it. And the email is, watch on demand. You'll see all the slides and the email again. Okay. Does it promote M2 macrophage phenotype and affect net formation?
Well, no, the biofilm will stimulate. No, that's a very interesting question on the macrophage aspect. The biofilm will cause conversion of M1 to M2 because M2 is an anti-inflammatory, a reparative phenotype of macrophages, and particularly Pseudomonas bugs can do that, tricking the immune system into an anti-inflammatory profile so it doesn't attack it, doesn't try to destroy it. Netosis, neutrophilic extracellular traps, for people that are unfamiliar with that, is a form of how your neutrophil kills invading species. Neutrophils also do it through the production of antimicrobial peptides, direct phagocytosis, and production of reactive oxygen species. But netosis is stimulated by the biofilm because that will cause collateral host tissue damage.
Great. Can we use it for fistula cavity wounds?
I put it inside these deep tunneling wounds all the time because that is full of chronic bugs and biofilm in there. I utilize it all the time in the OR, in the wound center, in the office. Any type of deep tumbling wound, make sure you get a good debridement, clean all that stuff out of there. Absolutely put it in there. Works really great if you have a collagen powder too, to mix those two together and put it inside there. Yes, you can. Fistula wounds, yes.
Great. With Pseudomonas, would you still treat with an oral antibiotic with the use of plastics?
I don't use any antibiotics unless there is the true indication of a IDSA guideline infection, big zone of erythema, bone, tendon, purulent drainage. Now, they probably should be in the hospital if you have those kind of, because they may need an OR procedure, so I can open that up and clean all of that out. But I treat 10,000 wounds a year. I've probably given 5 antibiotics in the last year for people that have true infection. Chronic wound is not a true indication for any antibiotic. There is no evidence to show that antibiotics, oral or IV, equate with wound healing. Zero evidence for that.
Thank you for that perspective.
Mm-hmm.
Another question, if 4 weeks have passed and by chance there was no improvement, would you persist with Blastex?
Well, yes, because again, when you have that chronic wound environment going on, you have to do lots of different things. Remember, we're just not going to say put blast on and everybody's going to do great. Everybody's going to do wonderful. Remember, think about the cause of your chronic wound and go back to that prepare to repair paradigm and think about all of those things that are going on in there. Maybe, remember, people with chronic wounds, lower extremity, need some type of an arterial Doppler. Maybe they have problems upstream with macrovascular concerns. Are you offloading it appropriately? What's their smoking status? What's their nutritional status? Did you get an X-ray to look inside there, MRI, things of that nature too? Lots of things go to a chronic wound. You need lots of treatments for that. But I continue to use the blast because there's incredible safety data. You could put it on every day for up to 30 days if you need to. Now, most of my patients I'm seeing once a week, maybe twice a week at the most, because they rely on public transportation a lot. But you have that safety and efficacy to continue to use that because of the great safety profile.
Great. And I think you might have answered some of the ones here. So we might just cut a few in. What is the protocol? So if not oozing too much, can you leave the dressing on for 5 days at a time before changing with appropriate dressings?
Well, sure, if you have an appropriate one. Now, I use a lot of something called Draw-Tex made by Ergo because it can absorb 2 pounds its weight in drainage. You'd be surprised, even have a little 1 centimeter wound. As soon as that leg goes down, it's in that dependent position. Gravity draws a lot of that fluid down in there. Again, so you have the safety of utilizing this for 7 days, but you got to use multi-layer compression in venous wounds. You'd be surprised how many people don't use multi-layer compression bandaging, and there's 3 RCTs to show that. You got to get rid of that edema. Edema is quite pathologic, slows down oxygenation getting to the wound. But at the same time, if you think that something is going to be heavy drainage, change the bandage more often. You have to wick away that inflammatory exudate. Remember, you got to use it in blast in conjunction with good standard of care too.
Yeah. I think I might do one more, and I can see the questions are still coming and they're actually becoming more hands-on, tangible, which is awesome, but that might give us ideas for if we do something next year, you know, that we do a part where there's a lot of question answer, because I can see it's so valuable. So let's just go for this one. Is it safe to use plastic in conjunction with compression therapy?
Do it all the time. Majority of my
let's just say that was a great answer. And the last one, is it okay to leave Blastex for 1 week or is it too long?
I do that all the time as well. Now, the efficacy is up to 5 days because sometimes people can't get back. Okay. But yes, its efficacy is for 5 days.
Fantastic. Thank you so much. Have another sip of water while we wrap up. And thank you, everyone. Jana will now put the survey in the chat, and we'd really love for all of you to just take 1 minute, even if there's, you know, kids that need to go to bed or whatever's happening in your world, just 1 minute for all of those listening next time. So share any ideas for what you'd like to hear more about. And please
email me your questions. Please email them. Keep them coming. I love to answer. Love to talk.
That's very nice of you. Thank you so much.
Anytime.
So the survey link is there. And Nicole, if you just move the slide, I think we've got a QR code as well on the next slide. Yeah, for those that prefer. So there's a link in the chat, and you can, with your phone, if you're not listening at the phone as well, grab that QR code, and you can continue replying to the questions when we finish here. I just want to make sure that everybody gets access to the survey while we're here still. And what I might do is, while people are doing that, I might just thank you, because this was a whirlwind. You know, we
Yeah.
passed through technical issues and still delivered amazing value within an hour. So thank you so much for a great presentation.
Love it. Please email me
S-
anytime.
Yeah, so knowledgeable, and it's really, we can see from the comments, been very valuable to those participating today. And we know that a lot of people watch on demand. So it's up on our website from tomorrow. So you might get more emails coming through for
I
those
love
that
it.
watch it on demand as well. So to all of you participants, you will get an email from Team Medical tomorrow with the link to your certificate PDF for the CPD point, and as well the link to the recording. And you can continue doing the survey even when we wrap up. So continue doing that. And then just enjoy, Dr. Rogolski, all the likes and thumbs up and hearts and claps in the chat.
Great.
And thank yous. You're an absolute wealth of knowledge. Thank you for sharing your time. I love this. I live in rural areas. You know, this would be so great. That's a very good point, because we have that issue with a lot of rural areas that can't get to it. More wound webinars, please.
I'd love to do it. Let's do one next week. I'm good with it. You let me know. Anything I can do to help?
Early morning or late
Anything I can
night? Should we
This
swap
time
it
is
next
fine.
time? We get up early and you.
I'm always an early riser, Annalena, so it's no problem.
I am too. I might move to the US then. You come here and we.
I know, right?
No,
It's wonderful. Anything I can do to help out, that's my job.
Fantastic. And to all of you, you might guess that this is why Oraderm is presenting with us, that we are now supplying it. You can buy the plastics through us, which you haven't been able to do before. So please go and have a look on our website and send any questions through, because this might be new for many of you. So there's a journey, because we all want to know what we're dealing with. So please continue the questions coming.
Great.
Perfect. Nicole, any other comments from your side? We thank you so much for doing the slides from this side of the ditch. And we might just go to the next slide, double checking we have. Yeah. And that's really
It's a pleasure. Thank you, Dr. Rogolski, for representing our new baby Blastex. We really appreciate it. You did an excellent job.
Great.
And thank you to everybody joining on behalf of the Team Medical team and the Oraderm team and the Blastex team. We're very grateful. We look forward to working with everybody in the future with more education opportunities.
Yeah,
Love it. Thank you very much. Love to help.
Thank you. Enjoy your day. We'll
You too.
enjoy a good
Thank you.
sleep and catch up again soon.